Hi guys, Dr. Gillard. Let's go over this Lenke classification system. I know we had a lot of trouble today or yesterday on the examination with it, so I'm going to build this little PowerPoint YouTube presentation to help you and future students with the dreaded Lenke classification system for adolescent idiopathic scoliosis. So here we go. So here's a PowerPoint. You should have this in your notes, I think, somewhere. But here it is. So adolescent idiopathic scoliosis classifications. The king, the first one, was Ponseti. We don't need to worry about that. Or the king was, for many, many years, the king was the king. For nearly 2 decades, the research was full of king classifications. But it failed to include all the curve. It didn't have a double major or triple major. And it didn't take into account rotational or sagittal deformities. And it had poor intra-rater reliability. So it got the boot. In the early 2000s, Lenke and Scoliosis Research Society published their classification system, and that is still the king today. No pun intended there. It's still the champion today. The gold standard classification system is the Lenke classification system, and it is 2016 right now. Still doesn't take into account rotational deformity, and it's fairly complex as you students are learning. There's some other ones we don't need to worry about. So there's Lawrence Lenke himself, who is still in practice, still has a website. So this is the scoliosis god right here. Anyway, so we just said all that already. So what is it for? Who cares about all this stuff? First of all, you got to have a way to report different algorithms with regard to different types of scoliosis. So this classifies as scoliosis. So spine surgeons, spine professionals, researchers, we can all talk about them when we know what we're talking about. It's also, the grand scheme of things was to create a surgical algorithm to go along with the different classifications. For example, if a patient had a Lenke 1A curve, then you would do this procedure A to them and it would work out good. Bottom line is, I don't think none of the surgeons I know actually use it for an algorithm purpose. Everybody has their own beliefs or so, but so it's really it's more used for communication purposes and testing purposes. So I get to test you guys on this. All right, some tools if you're going to have a scoliosis clinic. You need the old-fashioned standing long 3614 bucking cassette are ideal. I suppose you could break it down. They got to be standing images. The lateral bending images are done actually supine, but I really don't think it's going to make that much difference if you don't have a supine. If you can only pick one, get a standing bucky for this. But ideally, why would they want lateral bending done supine instead of standing? That's right, because you're going to get a little bit more range of motion with supine once you take the rector spinae muscles are taken out of play. They don't have to work, so you might get a little better bending. You should also note here that leg length discrepancies need to be adjusted for. So if someone has a short leg by more than 2 centimeters, you need to put in a little heel lift before you take these images, or it'll skew your results. So nuts and bolts of the system, there are 6 curves: Lenke Type 1, Lenke Type 2, Lenke Type 3, and etc. up to Lenke Type 6. Then after the curve comes the lumbar modifiers. We always look at the lumbar scoliosis as long as it's over 10 degrees. Doesn't have to be a great curve, but we always want to address it. Why? Who cares? Because the $64,000 question in scoliosis surgery is, how far do you extend the construct down? The farther you extend the construct, the more inflexible the patient's going to be, perhaps more miserable the patient's going to be. But if you don't extend it far enough, you're going to get a crankshaft phenomenon talked about in the class, how it can twist right within the scoliosis, and that surgery doesn't work and it can be a disaster. So you want to classify the lumbar spines. The sagittal thoracic modifiers, negative, neutral, and positive, we're not going to worry about these. You guys have enough trouble with these. So lumbar modifiers A, B, and C. So if a patient has a Lenke 1 and you know he's got a type A lumbar modifier, you would write it as a Lenke Type 1A. Okay? All right. Another concept is you guys had trouble with. You have to be able to identify the apical vertebra, or at least the apical vertebrae. If there's two vertebrae that are far away from this mid-sagittal line here, then they call it the apical disc. But and you can take the one above to use that, the pedicles for rating here. So the apical vertebrae, what is it? It's the vertebrae in a curve that is farthest away to this mid-sagittal line. It's also in the lumbar spine, it's actually called the central sacral vertical line. I don't care if you call it the mid-sagittal line, though it's fine. And we'll see how to draw that in a little while. Okay, it's as simple as that. So the apical vertebrae, farthest vertebrae, or combination of vertebrae, that farthest ones that are away from this line. That's the apex of the curve. Okay, so now the recognized Lenke curves, don't get this wrong. There is a lumbar curve with an apex between L2 and L4. There's a thoracolumbar curve with an apex between T12 and L1. There's a main thoracic curve with an apex between T6 and T11. And then there's a high curve, a proximal thoracic curve with an apex between T3 and T5. Now for classification purposes, these two are lumped together. So we call this a thoracolumbar / lumbar curve. You'll hear me say it fast, thoracolumbar lumbar curve. Okay, so that's it. So we have a proximal thoracic curve, a main thoracic curve, and a thoracolumbar lumbar curve. That's it. There's three players in the classification system. 25-degree rule, you have to understand this. Now, in order to even play the classification game, the coronal curve has to be at least 25 degrees. In reality, it's got to be even more than this. But for starters, it's got to be at least 25 degrees. Even more than that, it has to be stiff enough not to reduce to under 25 degrees. For example, if you have a 30-degree curve to the left on a coronal view, and you bend the patient, lateral bend them to the left, and that curve reduces down to a 15, that curve is very flexible. It's called non-structural, and it doesn't get to play the game. It does not count in the Lenke classification systems. Okay, so it's got to be at least 25 degrees. I mean, really, it's probably got to be about 30 degrees because every curve is going to bend a little bit. I think 5 degrees. So, but it's got to be able to be stiff enough to not bend below 25 degrees. And when it doesn't bend below 25 degrees, the magic word is structural. And when a curve is structural, it plays the rating game. It gets to participate in the rating system. Okay, how to measure coronal Cobb angles. Now be careful. This was on the test. A lot of you missed this. Remember, there's a sagittal Cobb angle and there's a coronal Cobb angle. It's the coronal Cobb angle that we care about in rating and classifying the Lenke curve, all except for the kyphotic modifier, which we're not even worried about. So coronal means from the front. So here's the pieces of a curve, right? Here's the concavity. That's this part. It's kind of the cave. Think it's a cave going in. And then there's a convexity. So that's on top of the mountain, on top of the hill. Here's the apical disc. We have two apical vertebrae. L2 looks to be a little farther away from this, more lateral to this mid-sagittal line here, or central sacrovertical line. Okay, and how do you draw a coronal Cobb angle? It's whichever vertebrae are tilted the most. So first of all, we have the members of the curve. So all of the curve members will have a wedge pointing toward the vertex of this angle. So these are all wedged to the right. Say the wedge is pointing right. And then you take the highest member who is most away from a horizontal line, the most tilted, in other words. And the same is true down here. You take the one that is most tilted away from the horizontal line. So usually they're the most proximal and most distal members of the curve. and now the line is drawn from the top end plate, from the bottom end plate. Not always, though. Sometimes one vertebrae will be laterally flexed a little more than the final member. So it's the ones that are tilted away from horizontal the most. Just said all that. We said all that already. Okay, here's a new system coming in called Fulcrum bending radiography, and where you put a soft block here. So this patient would have, this would be her right side. So if she has an apex to the right, we're going to test the bending to the right to see if those curves reduce to under 25 degrees. Here's an image of it. Okay, there's the roll right there. So we have an apex here to the right. Heart's on the left, right? There's the heart, so this is the right. And notice it was 61 degrees, but with lateral bending it reduced way down to 31 degrees. So this is a pretty, not a super stiff curve, but it does it. The question is, does it play the classification game? Is it strong enough to be classified? Absolutely yes. Okay, because it's still above 25 degrees. There's a little lumbar curve down here as well. Well, maybe not so little, but that one probably would reduce. If this one reduced by almost 50%, I could almost guarantee you this would completely disappear. And so this would be non-structural, and we don't use that in the rating system. We would only use this thoracic curve. You'll see what I mean in a minute. What's, for those of you who have had this class before, or what curve is this then? This is actually a Lenke 1 curve. We'll get to those. The other concept is important, major versus minor. It's very simple. The major curve is the champion. It's the king. It's the one with the largest Cobb angle, plain and simple. You can have minor curves, but they're not going to be. The major curve is always the one with the greatest coronal Cobb angle, period. And you can also, according to the traditional system, the major curve is always considered structural. So you don't even have, patient only has one curve and it's big, you don't even have, you can assume, you don't even have to do lateral bending. You can assume that it's going to be structural if it's a Lenke 1. Minor curves can be structural or they can be non-structural. Okay, let's try a simple test here. So we have a main thoracic curve, 30 degrees. And we have a thoracolumbar curve, 43 degrees. Which one's major? Good. The biggest one, thoracolumbar curve, 43 is major. So this would be in the Radi system. If this stays above 25 degrees on, that would be right lateral bending, this will play. If it goes below 25 degrees, then all we have is this thoracolumbar curve. And that's a Lenke 5, which don't worry about that yet. Stiffness, we don't really have to worry too much about. This is more for surgeons, but a curve that doesn't reduce much upon lateral bending can be quite pesky. Conservative care typically doesn't do very well with it, anecdotally anyway, and surgery sometimes can be fraught with problems, crankshaft phenomena, all sorts of problems. So stiff curve is usually trouble, but we don't have to worry about that. Okay, let's get to it now. Here's the 6 types. So we have Lenke Type 1. Okay, this is aka major thoracic curve. For testing purposes, just say Lenke 1. If you want to impress me, you can put major thoracic, but I want to say Lenke 1. Okay, so it's, let's just not, without knowing anything, we can eyeball this and we can say, woo, that's a pretty good main thoracic curve, right? I don't see any proximal thoracic curve up here. I see a little thoracolumbar curve, but to me, I can already tell you without even bending, this is the main curve here. So when there's only one curve that's structural and it's a thoracic, then you have a Lenke 1. Simple as that. Lenke 2. So on this one, you can see that T1 is actually cocked into the concavity of the proximal thoracic. So we have a thoracic curve. So we have a curve here, and we have another big curve here. We have a little curve down here, but this is not big enough. I can just eyeball that. But let's go. I think I have a. Well, let's stay here for a sec. So let me define it. So a Lenke 2 means the main thoracic curve is the king. It's structural. It doesn't reduce, and it's major. It's the biggest, has the biggest coronal cob angle, period. The proximal thoracic curve is also structural. It doesn't reduce to under 25 degrees with bending into its apex. Okay, so it's still over 25 degrees, but it's just not as big with regard to coronal cob angle as the main thoracic curve here. So if main thoracic is biggest and this is second place, you have a Lenke type 2 curve, period. Here's a picture. Here's an example. So maybe on the test it would say, here's a patient who had a lateral curve in the main thoracic spine, major thoracic curve of 75 degrees, and a proximal thoracic curve of 45 degrees. Both were structural. What's the scoliosis? Well, all we got to do is figure out who's the major. 75 is major, and now we have a second player. We have a proximal thoracic curve involved who's minor. This is by definition a Lenke 2 curve. Okay? As a matter of fact, if the main thoracic curve is major, then it's going to be either Lenke 1, Lenke 2, or Lenke 3. All of those systems have the main thoracic curve as the major curve. And maybe even Lenke 4. That can be either thoracolumbar, lumbar, or main thoracic. Okay? Lenke 3, or the double major curve. Okay, so we can obviously see thoracic is by far the deepest curve here. And then we have a lumbar curve here. Thoracolumbar lumbar curve is a player as well. So all we know, if the main thoracic is the biggest, if that's the major curve, and this is the minor curve, and they're both structural, then we have a Lenke type 3 curve. Okay, so here's the question. Let's say this patient came in. They had two structural scoliosis, an 88 degree main thoracic and a 78 degree thoracolumbar lumbar. What's the classification? Well, this is major, so it's a type 3 by definition. It's a Lenke type 3 curve. Okay, got it? Here's a Lenke 4 curve. Now this is interesting. This is all three regions of the spine have a structural scoliosis. Period, end of sentence. Now in this one, it doesn't matter if the main thoracic is the major. In this case it is. But the thoracolumbar lumbar could be the major. I could reverse these numbers and it would still be a Lenke type 4. Doesn't matter as long as one of these is the major curve. So you got to have three structural curves. The main thoracic or the thoracolumbar lumbar has to be major. Then you have yourself a Lenke type 4 curve. Got it? Lenke type 5, okay, aka thoracolumbar lumbar curve. So here you can just eyeball it. You can see we have a big thoracic or thoracolumbar lumbar curve, 68 degrees. We have a little one here. I didn't even mark it. It's so small. It's maybe 20 degrees or so. But that's not going to hold up on bending. So we have only one curve, and that one curve is either a thoracolumbar or a lumbar curve. Then we have a Lenke type 4. Okay, simple as that. Now Lenke 6. So we have two structural curves now. Okay, we have a main thoracic curve and we have the thoracolumbar lumbar curve. Thoracolumbar lumbar curve is bigger, right? So this is major. So whenever you have a major thoracolumbar lumbar curve, when that's major, it's either going to be type 5 or type 6. So type 5 means it's the only structural curve. Type 6 means that the main thoracic curve is also structural, but it's minor. It's not as big. That's a Lenke type 6 curve. So there it is. Play this back until this sinks into your head. Now we'll talk about the lumbar spine modifiers. They're not that complicated. So as we just said before, the lumbar curve is important. It'll help us decide, in a fusion anyway, how far to extend the fusion proximally. So as long as the curve is over 10 degrees, you're going to rate it. Why, if it's under 10 degrees, why wouldn't you rate it? because that's not a scoliosis. By definition, a scoliosis has to be greater than 10 degrees on a coronal Cobb angle. Okay, and everything, the star of the show is this mid-sagittal line. The lumbar spine, the pioneers of this rating system call this, even this actually comes from back the King days. This is from King's system. They carried this forward. It's the central sacral vertical line. You just draw the intercrustal line, which is a line going right through the iliac crest tops, and then you drop a line perpendicular to that falls right in the mid-sacrum, right through the spinous tubercles of the sacrum. And there it is, extended up. And then figure out, so make the line, now figure out which one's the apical vertebra, which one's farthest away from this line. It's definitely L3 in this cartoon. Okay, and then all you do is you assess the concave pedicle. This is the concave pedicle. This is the convex pedicle because it's closer to the hump here, the top of the curve. This is the concavity, concave pedicle. So it's simple as this. If the line bisects both pedicles, it's a type A. If the line falls on the concave pedicle, it's a type B. If the line falls inside this pedicle, some of the papers said inside the vertebral body, but I'm just using the pedicles. Usually the pedicle would be out farther than this. If it falls, if it's outside, if it's far lateral, then this is a type C. Okay, we can even talk about those more. I just explained that. There's what it looks like on a radiograph. Just explained that. Just explained that. Picture's worth 1,000 words. Let's take a look at this cartoon. Okay, so here's a slight scoliosis here. It's got a slight lumbar curve. It's probably 15 degrees, maybe a little more. Obviously, it's got a big thoracic up here. So which one's the apical vertebra? It's the one that's farthest lateral this way to this central sacral vertical line. So it's probably this one right here. You could argue that it might be this one. It might be a disc, might be an apical disc between 3 and 4. But it doesn't matter because they're both, the line is inside of the pedicles. Right, way inside. We're looking at, this is the marker, right? It's the concave pedicles is the one we're looking at, and it's not even close. So this is definitely a type A. Type A also means it's a pretty shallow lumbar curve. Type B, now look at the pedicles. Now in this curve, this is definitely the apical vertebra. So look at the concave pedicle. The central sacral vertical line is going right through the concave pedicle. Type B, simple as that. Type C, we got two vertebrae that could be farthest away. So either one of them, it doesn't matter which one you use, because the pedicle is far away from that central sacral vertical line. See, it's way outside. So this is a type C, and it goes with a more severe type of scoliosis. Here's a nice test question. Which lumbar spine modifier is associated with a more severe lumbar scoliosis? Type A, B, or C? It's got to be a type C. There's the sagittal thoracic spine modifiers. They go by kyphosis. We're not going to talk about these, but let's just not even talk about those. You guys have enough trouble with this system. Okay, let's try some real ones now. All right, let's just eyeball this. So we have a nice, is this an adult or is this, well, what's that right there? Good, riser sign. So this is definitely an adolescent. So this is adolescent idiopathic scoliosis. We got two pretty good curve. We got a pretty big thoracolumbar curve, and we got a pretty big main thoracic curve. So these are probably both going to be structural. Let's put some lines on them now. And I mean, you can eyeball too. We could draw an intercrustal line with our mind across here. Extend this up. So it's either going to be an A or B just by eyeballing it. But let's put the lines on there and see. All right, so pretty close. So we have a 45-degree main thoracic scoliosis, and we have a 40-degree thoracolumbar scoliosis. Which one's major? Ah, excellent. 45 degrees. 45 is bigger than 40, so this is the main thoracic curve, or the main thoracic curve is major. So that immediately tells you the rating system, there's only, well, there's four. It could be Lenke 1, Lenke 2, Lenke 3. Lenke 4 technically, but since we don't have that third curve, it's got to be Lenke 1, 2, or 3. Well, Lenke 1, that's only one structural curve. We have two structural curves. Now, I would have to tell you in the problem that both of these curves are stiff and structural. So, but since this is main, this is a Lenke 3, right? The Lenke 2 was the main thoracic was structural and major, while the proximal thoracic was minor. There's no proximal thoracic. Lenke 3 was the main thoracic was major, and the thoracolumbar-lumbar was structural and minor, and that's what we have here. So we have a Lenke 3 curve. Now let's do the lumbar modifier. Okay, there's a central sacrovertical line. Let's, even before we look at it, let's figure out which vertebrae is farthest lateral. It's got to be these two. It's probably a tie. It's probably would be this L2 disc, but it doesn't matter. Neither of the pedicles have breached the line, so this is still what? It's still an A modifier, right? Because the concave pedicles are still, they still have not went lateral to that line. They haven't showed up over here. So this is a Lenke 3A. Okay, there's everything. I explained it to you. Lenke 3A. Or double major. Let's try another one. How about this one? I don't think I drew lines on this, but let's say neither of these, this is a stiff curve, neither of those decreased to under 25 degrees on lateral bending at the apex. Well, this is another one, right? This is major, this is minor, so this is a Lenke 3, and we can eyeball that. That's got to be a 3A again, just by eyeballing it. Another double major. And I drew that on there just to be show you, because there's the lumbar curve, so this one's probably the apex. So we're looking at these pedicles, and none of them are far enough away lateral. None of them had shifted toward the apex enough to even get to a B, so that's definitely an A as well. Okay, let's try this one. Here's another one. Let's eyeball it. Okay, we got a pretty, that's not very big lumbar curve there. Much bigger main thoracic curve. I see maybe a tiny eyeball in it, maybe a tiny proximal thoracic curve, but it's not, I'm not enough to even draw lines on it, I would say. Let's draw some lines though. Okay, so this one comes out to 28 degrees, 63 degrees. So the test question would say, so supine lateral bending images show that the main thoracic curve reduces to 58. Is it still structural? Yeah, it hasn't went to under 25. It's still structural. And the lumbar curve reduced to 18. Is that still structural? No. So it doesn't play the game. It's gone. So all we have is one structural thoracic curve. And so this is a what? Lenke 1 scoliotic curve. Now let's do the lumbar modifier. Okay, intercrystal lines are right here. Okay, we drop the perpendicular through the transverse tubercles. And now we just need to find which one of these is farthest lateral. So one of these two here, I would say. This is kind of a strange one. Doesn't matter though, because here are these are the pedicles we use, right? The convex pedicles, these are the ones we use to make the curve. So none of them are over here, right? This would have to be shifted way over here. So these are right in the center. So this is definitely an A. So this is a Lenke 1A curve. Oops. Lenke 1A curve. Okay, I think that's enough. I hope you get that now. It's not that hard. Go through this a few times if you're having trouble. And I hope that helps, and we will see you around school.